So hello everyone and welcome to today's Lunch and Learn, which is organised by North Cumbria Integrated Care Library Service and CLIC. It's good to see everyone here today. I'm especially pleased to welcome Helena Gregory and Katie Meller, and they will be delivering a session today on anticholinergic burden, evidence into practice. So the next slide will just give you a flavour of the ideas of these Lunch and Learns. And Helena, if you could just pop onto the next slide, we're just asking that, or just informing you, sorry, that it's an informal space for health and care staff to come together to share experiences, to learn something new related to health and care, to focus on quality improvement and be signposted to any further resources, and of course, eat your lunch at the same time whilst listening. And the next slide will just give you a few protocols for our session. So please keep your webcams off unless you've been invited. Please make sure that you are on mute when you're not speaking. And please note that we will monitor the chat, so you can pop any questions or issues or spontaneous contributions into the chat, and we can answer any questions at the end. Please also be aware that this session is being recorded, and you can view all of the previous Lunch and Learns on the CLIC YouTube channel. Please also pass it on, spread the word and share the learning. There will be a quick survey posted into the chat just so we can get your feedback. And of course, you can also suggest any future topics or any speakers that you think would be good for these Lunch and Learn sessions. So without further ado, I will pass you over to Helena, who will begin the presentation.
Thank you so much, Tracy, for the introduction, and thank you everyone for joining today to hear about anticholinergic burden, what it means, a little bit of information behind it, a bit about the evidence around it and how that has grown over the last few years, and then how you might use that in practice looking at medicines for urinary continence in women. So before we start, just a little bit of a clinical recap for you. So acetylcholine, which acts on the parasympathetic nervous system on the muscarinic receptors. So you might hear it referred to as anticholinergic or antimuscarinic, and it produces an effect there when it does that act. So for example, if it's smooth muscle movement in the bowel and bladder, then it makes you pee and poo. And anticholinergic medicines, also known as antimuscarinics, they block this effect and stop it from happening. So sometimes this can be really useful. So for example, in palliative care, where it might be drying secretions, which can be very distressing, in neuropathic pain management, amitriptyline, for example, it can be really helpful. But however, on the other hand, medicines with a high anticholinergic burden, so where it has that greater effect, can increase the risk of cognitive impairment and decline in older people. And there is an association with an increased risk of developing dementia and early death. Depending on how specific they are, they might have common short-term adverse effects. So they might cause a dry mouth, for example, constipation, urinary retention, drowsiness, or blurred vision. And if they act on a very specific receptor, such as the M3 type, smooth muscle in the bowel and bladder, then they will act there and not have as many effects on the brain. So if, like me, you are a fan of Despicable Me, it's a bit like Gru and his minions. You're not quite sure if it's a hero or a villain or something in between. So first of all, I want to share with you a bit of information about a project that we've done over around the last 6 years. And we had a look at some data which is available on a data set for prescribing called EPAC2, looking at polypharmacy, looking at how medicines could be prescribed in large numbers, sometimes appropriate, sometimes that can be inappropriate. And we had a number of metrics that it gave us, which we shared with our general practices at meetings, looking at benchmarking against our colleagues in CCGs as was. You can see in these data sets, North Cumbria is the dark blue bar amongst similar CCGs, which are the light blue ones. And we could also see this at practice level. So we looked at this for a lot of different things. Some of them we weren't so good at, so having a look at anticholinergic burden, and some of them we were really good at. So where people were taking combinations of medicines that could lead to acute kidney injury, actually we were really good. So it was a time to celebrate that and have a look at the success and think about what we were doing there, but also enabling our practices to choose what they wanted to focus on based on where we were outliers and where they had concerns, gave them a sense of ownership as we worked through over the next few years. So for the following year, we put it into our practice work plan. And you can see how over time from the baseline where we were a real outlier in this particular indicator that we'd chosen, looking at older people with a higher anticholinergic burden score, we improved quite a lot over time and came down. We'll have a look at the outcomes later. And we also put in a number of resources for our general practices to work through. But then we hit a bit of a snag. So at the time, a lot of the evidence around anticholinergic burden was changing quite dramatically, and it has continued to change from when we started this in 2017 through to now. So actually where we started out from, we've actually really changed. And I just wanted to tell you a little bit about that story because it was a question that really taxed us. So there were a lot of different ways of measuring anticholinergic burden, and some of them, such as this one that I'll go through in a minute, have an evidence base behind them. Some of them, previously we didn't have that, and so it was from an expert consensus. So you might come across different scores or slightly different calculators or slightly different ways of working out, and that's okay. Some of them just take into that effect on cognition, some of them take into the wider effects, some of them mix the two in slightly different ways. But if you do want to read more, there is some information in the press quit bulletin that clinicians in North Cumbria have access to. So really, we wanted to pick a chart to use with an evidence base that we could tie in with our other resources and try to be consistent, all the while accepting that there might be some grey areas within that. So this was one of the charts that we'd chosen, and this was one of the first evidence-based ones, which came from a piece of work by Bishra in 2016. So this is the AEC, which is a 3-point scale, and that's the anticholinergic effect on cognition. And that had a look at the in vitro potency and the capacity to cross the blood-brain barrier, so how it exerted that effect. And it had a look at standard texts to do this. So, for example, the SPCs and some of the trial data around the drugs that was available. So we've got a calculator and we can start to think about how we build up our resources around it. And one of the reasons that you might choose to have a look at this one is because the evidence around that risk of dementia is increasing all of the time. So in 2018, there was some further evidence from Richardson et al. And you can click on the links if you do want to read these original studies, which for the first time showed evidence around a real association between long-term use of anticholinergic medicines and the risk of dementia. A lot of previous studies just looked at that short-term use, which is why it built in that wider anticholinergic burden short-term effects rather than the longer term, because in this case they looked at exposure periods of up to 20 years. So they followed people through for 20 years to see the medications they were using and the risk of dementia. And because it included very large numbers, they could look at class effects of anticholinergics. So some things that we had thought were perhaps more risky and that you might see an anticholinergic burden score for, you might see, for example, an antipsychotic medicine or a gastrointestinal medicine such as a PPI. But actually, while those do have some slight anticholinergic effects in the short term, they don't increase the risk of dementia in the long term. Quite interestingly, if you take a gastrointestinal medicine, it actually reduces the risk slightly. So although it's got an ACB score in other calculators, actually the risk of dementia was slightly lower with that. But there were some classes that it did increase the risk of. So in that case, you would be having a look at antidepressants, urinary medicines, which we'll talk about, and anti-Parkinson medicines, which did seem to have the effect. But what is that effect on an individual? So everybody, of course, is different, but there is that baseline average risk for an average person. which for dementia, about 2 in every 100 age 65, and that rises with age to around 1 in 3 by the age of over 90. And your personal risk can then be affected by a lot of other things. So your mental, physical and social activities. Your typical person aged 65 to 70 has about a 1 in 10 risk of developing dementia over the next 10 years. But adding in a medicine, say with an anticholinergic burden of 3, an AEC score in this case of 3, would raise that to around 12%. So from 10% to around 12%. And calculating that number needed to harm is 50. So for every 50 people prescribed one of these higher risk medicines, one may get dementia because of the prescription, which is quite a scary thought because we want the medicines, of course, to benefit people. In 2020, Bishra brought out another paper, which was having a look at the risks of mortality and hospitalisation for people with dementia in line with the medications. So patients who have dementia who receive medication with a higher anticholinergic activity do appear to have worse prognosis in terms of mortality and hospitalisation risk. It is a small risk, so it's increasing your risk of admission to hospital by about 3% over your own personal risk, and the risk of death by about 2% for each additional AEC point that you give. And bearing in mind, some people might be on 2, 3, 4, 5 different medicines and may have a score of 10. So actually that increased risk could be quite high, particularly where we've got the combinations, which Katie will come on to talk about later. So having thought about the evidence that we had, bearing in mind we didn't have that level of detail at the time, we were kind of starting halfway through the story and constantly changing what we were doing as we went through. Our next colleagues pulled together some resources which they shared at our practice prescribing meetings, either at the practice's own meeting and where we bring our GP prescribing leads together to have those conversations. So we put quite a few different things in, setting off with a quiz, bringing that fun competitive nature into it. Could you categorise the drugs? Do you know what the score is? And then making sure that you have a copy of that to take away with you as well. And then case studies for clinicians to work through stepwise. So bringing their own examples, finding success from their world, and also some worked examples that they could go through if they didn't have that available. And we do also have Prescripts e-learning. Again, if you would like to have a look through, clinicians in North Cumbria can sign up to this to have a read through. So in practice, we had to identify our patients with the higher anticholinergic burden scores. We had to prioritise them because if you have several hundred patients, where do you start? Actually, you want to start with those where you might have the greatest effect. And then making sure that this information was added into the record. So, for example, the score was recorded in medication reviews and the number of recent recorded falls, because in some cases, as we've discussed, it might make someone feel a bit dizzy or confused. So we would explore with them the risks and benefits of their medicines, taking into account the cumulative effect and any comorbidities, and actually which treatments are important to that individual, which Katie will go through later on about how you can do that in practice. And then it's just reviewing those patients regularly. So once you've had that initial conversation with them, there might be follow-ons from that as well as things change in their healthcare. But in terms of this, you would quite often be saying, can we switch? Can we step down? Can we stop? What are the different options? What else is available for you? So now just to have a focus on urinary continence and have a think about some of the medicines and some of the evidence behind that. So many of you will be familiar with NICE guidelines, and this is an example from NICE guideline NG123, which is having a look at women and urinary continence, and you can see the pathway there and the flow chart. So this is replicated in our health pathways within North Cumbria, which I'll give you a link to later on, and it really brings it to life for you. But this links through to the evidence base. And if you want to read the full guideline, you can. It is about 200 pages long, but there are small bits that I'm going to pick out for you today. And the first one, just in the flowchart, I just want you to have a little look at the slides at the bottom left-hand corner, and you can see a little tiny green box underneath all of those other suggestions and after all of those other suggestions. That little tiny green box is all of the medications. Now, quite often with prescribing for urinary continence, we might think actually, let's go for the medicines because that's going to solve the problem. But as we work through, you'll perhaps see why it's got the place that it has within that. And it's just remembering that is where it sits. So even looking back 10 years to the old NICE guidance, CG 171, which came out almost 10 years ago now, we can see the numbers needed to treat. So there are different options available for people. So for example, for pelvic floor exercises where that's applicable, that has a number needed to treat of 3. And that means for every 3 people, on average, 1 of them will become dry and continent as a result of doing the pelvic floor exercises. For bladder training, that number needed to treat is 6. So it's a little bit high. You have to take 6 people through that process in order for it to work. And for a pharmacological intervention, on average, that is 7. So actually saying I would need to treat 7 people with that medication in order for it to work. And you can start to see actually why we would perhaps put that a little bit further down the list, because it doesn't work for as many people as for some of the other things. And of course, the other thing with the medication is that people may think they need to take it lifelong, whereas for the others, sometimes it can be that short course, job done, someone goes away, sorted. So within the NICE guidance, again, you've got a list of tables that you can have a look through. And I know at first glance, this looks a little bit complicated, and it's delving into all of the trial data that we've got available and how well things work. So within that table, your middle column, which talks about your continence, so that is somebody considered to be dry at 12 weeks? Is it working well for them after 3 months of starting the medication? And the discontinuation in the right-hand column is, did they stop taking it? Now, there can be a number of reasons why. It can be because they got side effects, so actually they were caused harm by it, or it could be that it didn't work for them and they've stopped taking it. And of course, there's an awful lot of people in between those two groups as well. And it does pain me as a pharmacist, as you'll see from this table, that there's a real lack of evidence of effectiveness of some of these medications. And the absolute probability of someone being dry, of it working well for them at 12 weeks ranges from 12%, that's 1 in every 8, to 21%, which is 1 in every 5. So it's actually not very many people, sadly, that it works for. The probability of stopping taking it, as we said, for various different reasons, ranges from 15%. So that's for the M3 specific medicines that we talked about right at the beginning, such as solifenacin and darafenacin, which work specifically on the bladder, to 31%, which is almost 1 in 3 for oxybutynin immediate release. So these evidence trials are considered to be of high quality. So just looking at a couple of examples for oxybutynin, more people discontinued it, 3 out of every 10, than actually became dry and continent at the end of 12 weeks. Which is quite a thought, isn't it? And in trial solifenacin, as we said, that's a very specific one, the same number of people dropped out as it actually worked for. So you can start to see now why the position is in the way that it's in. But a lot of people might get some benefit, they might get some adverse effects, but we need to understand their experience more closely. And that's where speaking to the patient comes back in, to understand their experience by asking. So for example, using a bladder diary to understand whether it's working for them or not, to understand whether they're getting side effects or not. When you're having the conversations about, is it worth starting? Where are we starting from? Is it worth carrying on longer term? And then some of you might be aware of mirabegron as well, which isn't in the list. So this isn't an anticholinergic, although it does have its own effects and risks around cardiovascular disease. But it's important not just for us to be aware of this in the conversation, but also to make sure that the patient's expectations are right. So if we know that for a lot of people it's not going to work, that is okay. That's fine. So when you're having these conversations, some people might like the numbers that I've just shown you, and some people might actually prefer a visual. So this is an example MediCheck, which uses the AEC score that we talked about before, and it has it as a red, amber, green. So green is your score of 0 there, your red, your highest score of 3, and then you've got your yellow, your score of 1, and your orange, which is your score of 2. It also brings in the short-term effects that we talked about separately, such as dizziness and drowsiness. So if somebody has concerns about that side, then you might be looking more at those. If they have concerns more around cognition now or in the future, you might be looking more at the AEC. So visualising for some people can make it a lot easier. Other people might prefer the numbers and might ask you for a little bit more detail. So many of you will be familiar with shared decision making. This is the 3-talk model that we use in medicines for shared decision making. And in team talk, you're thinking about what's important to the patient. So at the outset, you might be noting people's activities that are affected by acetylcholine. So for example, thinking about urinary incontinence, it can be really distressing for somebody. It can be really affecting their quality of life, and we need to make sure that we're listening to that. But equally, we need to make sure if they've got concerns around something like constipation or dementia, which may be adverse effects, we need to be listening to that equally to make sure that we're giving them the risks that are important to them. And then in the option talk, we're talking through the risks in the way that's right, using the numbers, using the assessment tool and red, amber, green, and thinking about the priorities that they've come up with. So actually, if they're really concerned about falls and dizziness and drowsiness, then we're going to be concentrating on that for them because that's what they've told us. And then you're coming through to that decision talk and deciding what options am I going to do. And this is where the language is really important to think about. So the trial starts, the trial stops. It's okay to try it. It's okay if it doesn't work, we can stop it. And that reassurance that if something isn't working or causing side effects, that's probably what's going to happen and that's okay and that there are other options. But then we've talked about those other options. I'm not sure if you're aware of our local services. I'm sure many of you will. And hello to the bladder and bowel service if any of you have joined from there today. This is our local specialist nurse-led service, which is comprised of a small team of specialist nurses and practitioners who have fantastic knowledge around bladder and bowel. And that's in the community and in the community hospital as well for the outpatient service. So they have all of the different options that we've talked through and can support patients along with the advice and support as we go. You can either access and refer in, there's a link there to your health pathways, and there's also the direct information. If you do want to read more, then there's a file embedded there which has got a little bit more information about the team and the offer there. So please do get in touch with them for these patients so that they can go through the wide range of options. So I'm going to hand you over now to Katie Mellor just to talk to you a little bit about what this has been like in practice and in the work that Katie's done.
Thank you, Helena. Can you hear me okay? Can
Yeah,
you hear me all right?
good.
Yeah, brilliant. So as Helena said, I'm Katie Mellor. I'm a pharmacist working for Next and I work in Brampton and Longtown surgeries. So how does this all work in practice? So as Helena said, we've been reviewing patients' ACB score for a number of years now, but more recently we've started doing structured medication reviews within practice. Now, structured medication reviews, for those of you that don't know, is a more detailed medication review, but it's got a more holistic approach to it. And one of the parts that we cover is the anticholinergic burden score. So I also want to talk to you a bit about shared decision making as well as Helena, because we can't discuss the ACB score with a patient without shared decision making. It's just so important that the patient understands the importance of reducing their anticholinergic burden score. But how do you start that conversation? You can't just suddenly launch into that because patients just won't understand it. So you could ask something like, tell me how you're finding taking your medicines, and that may give you the insight into any adverse effects that they're getting from their medicines. You could also say, are there any medicines that are causing effects that you don't like? And that gets the conversation going. And this can then lead to you talking about their ACB score. it can be difficult to explain the ACB score to patients, but I try to explain it in the context of adverse effects and how, due to a number of different factors, each medicine has got a score attributed to it, and this will equate to how likely they are to experience these adverse effects. I do mention their overall high score, but I tend to focus on the individual medicines rather than the score, and it's making sure that that patient wants to know that information as well before you launch into it, because sometimes I know I'm the same, that you have this agenda and you think, I want to tell that patient all about these adverse effects, but maybe that patient doesn't want to know about those adverse effects. So before you launch into it, it's making sure that they do want to hear this information that you've got. And it's trying to make it understandable for people as well. I find this the hardest part actually of shared decision making, knowing how to gauge that information, because we've all got that information in our head, you know, we've studied it, we know it, but how do you then tell somebody about it? So that can be really difficult. So it's using your consultation skills. It's actually letting that patient tell you a little bit about themselves, and then you'll understand a little bit more about what's important to them. So it's making sure you find out what's important to them, because you never know what you'll find out because of it. So I've just got a couple of quick case studies. One is a 70-year-old lady, and she had a anticholinergic burden score of 8, and there were 5 medicines that just had a score of 1. But one of them, promethazine, has a score of 3. So I used the ACB calc calculator for the ACB score, and that came out with promethazine as a 3. And then once we'd discussed the promethazine, she actually was explaining that it's not really working for her. She was taking it at night to help her get to sleep, to it just not working. So we had a discussion about the risks and benefits of stopping it, and she ended up stopping it, and it was fine. So I think what I'm trying to say about this case study is chat to that patient. It may be that they're not actually taking that medicine. And the other case study quickly was a 75-year-old lady. She had an ACB score of 7. One of which was solifenacin. Now, solifenacin on the ACB calc has a score of 3, but on the MediCheck has a score of 1. So we discussed the solifenacin, and again, she was saying, well, it's not really working. So we decided together that we would try just a 4-week trial of not taking it, and I reviewed her a couple of weeks later, and she was struggling with it. And with discussion with the GP, we then referred her to the bladder and bowel service. So I think those 2 case studies, I just want to show you that chatting to that patient can really help reducing that anticholinergic burden score. Thank you.
Thank you so much, Katie. It's great to hear some practical examples. Just before we finish up, I would like to share with you the outcomes from the work that we did. As I say, it started back in 2017, and this is having a look at the prescribing data for people with an anticholinergic burden score of 6 or more who were older. Again, we know that is where the risk is, particularly for dementia and for links with falls and so on. And you can see the blue line there went down from very high, significantly above the national average, to significantly below. If we look at people with a very high anticholinergic burden score of 12 or more across all the age groups, you can see that again that's gone from above the average to virtually 0, where it's remained over time. So this is something that's now become embedded. And of course, it's not just the data. Our clinicians were really pleased to do this as well. And they said that it felt like they were making a difference for those individuals. And of course, it's always thinking in each review that you're doing, as Katie said, it's that risk for that individual person from the adverse effects of the medicines that we've been prescribing them that either aren't working or are giving them adverse effects. So just to finish up with a few take-home messages, Be data driven, but please talk about it. It's what you do with it that counts. Don't just let your data sit in a book somewhere. Celebrate your successes and improvements, as we're doing today, to share the success of all of the clinicians and patients who've been a part of this work over the last few years. Use the tools and evidence as part of the shared decision making, but keep yours and your patients' options open, including making sure you explore those expectations with them, as Katie said. So just to finish up, I think driving through all of these, many of you will know Lely Obo, one of our fabulous pharmacists nationally, and as she just said about medication reviews, please be curious, and that applies to all of this. So thank you very much, folks, for listening today. It's been great having you.
Thanks ever so much, Helena and Katie. What a brilliant example of putting evidence into practice for decision making. And I'm sure you'll all agree, what a great example of a holistic approach to patient care. So thank you very much. I'm afraid we don't have much time left. So if you do have any questions, you can post them into the chat and we will try and get a response to you as soon as possible. And please do leave your feedback. There's a link to a quick survey form posted in the chat again. And you can let us know also for any future topics or speakers. And on that note, the next Lunch and Learn will be on the 17th of March and is about compassionate leadership. Thank you very much, everyone, and do share the learning from today.